There being no quorum here, shall we begin with the presentations? Yes. Okay, yeah. Well, call to order. Let's stand for the Pledge of Allegiance, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. And we have a roll call.
Kathy Bruck.
Present.
Let's see, Marianne Salem.
Present.
Frank Labarge. Donna Williamson.
Present.
Dr. Hendricks. Supervisor Jean Bishop. Terry Williams. Maggie Wilcox and Dr. Wynn are absent.
Committee report, please.
I think I would know that. Good evening. Just to give you a brief update of where we are, if you'll remember 3 years ago we did our first countywide community health assessment, which many of you were involved in as Board of Health members. And following that, we developed our community health implementation plan, which we've been working on. We've had various work groups working on some of the issues that were identified as leading health indicators for our county. But one of the areas that we combined substance abuse and mental health into one group at the time because we just were short for people to be involved in the work groups. But recently we had everybody reconvene again, and it was determined that the mental health should be a work group of its own. And I am so pleased. We have such a problem with mental health issues in this county. I am so pleased that Maria Luna Wolf agreed to lead that task force. And she is here tonight to give you an update of what they've accomplished in probably 3 months. It's amazing. Maria is a clinical nurse specialist in psychiatric nursing. She's on the Mojave County Community College faculty, and she's a part-time nurse with hospice right now. So we're pleased to have Maria give you an update on the mental health task force.
Thank you, Patty. Good evening. Thank you for the opportunity to come and share with you sort of my excitement about this mental health subcommittee. I've been in Mojave County now for 3 years and have been involved with the care of mentally ill people and the concerns we have about them. And we have resources, but we don't have enough resources. I'm sure that's not news to you. But the committee that I chair started meeting in January, as Patty said. We sort of came out of the, as she said, the substance abuse group in recognizing that there is a need for some separation there, although there was many opportunities for linkages also. Many opportunities there not to separate the two, but we felt that there was some additional attention needing to be paid to specifically mental health. So the group of us, there's about 12 of us now, got together, and we've been meeting once a month since January. And as we had our discussions about the direction we might take in our early stages here, the significant piece that came up from the committee members was we need to do something about the stigma associated with mental illness. It's still alive and well after all these years, and we trace the roots of where stigma came from from medieval times to the present. And unfortunately, it hasn't changed too much. There's still a great deal of guilt and shame and those kinds of negative aspects related to mental illness. And the committee felt that we needed to begin there with some education programs. So we are going to develop, we hope, programs, at least 5 for each of the 3 cities, to share with groups that we will identify, to give them an opportunity to talk about what their knowledge of mental illnesses are, what the situation in the county is, and try to invite them into some dialogue so that people begin to have some sort of comfort level talking about mental illness. And right now that doesn't exist. There's a lot of discussion in the news about mental illness, it seems, as related to violence and that sort of thing. But on a more local level, what do we do with people with chronic mental illness? What do we do with people with acute episodes that are in our emergency rooms? As you know, we only have 16 beds of inpatient care in the entire county. But given all that, we still felt that we needed to begin with an education program. So one of our goals is to present those programs. And in addition to that, focusing on education, several years ago, the M-STEP, which is a substance abuse group that still is active, put together a community resource guide for mental health and substance abuse services. And as we hear often from professional groups, the frustration over not having resources or not having access or not having knowledge of resources. So we decided to undertake the task of revising and updating that resource guide. So we will do that on a county basis and make that available to professionals and non-professionals and anybody that may be interested in knowing. We do have resources. There are some out there, but they seem to be somewhat scattered, and we hope to bring those together in one document so that we can share and make other people aware. So those are the kinds of things that we decided for this term or this period of time for the community health assessment, and we will move on from there. But that's our beginning, and so we look forward to doing that. So you may be hearing from our groups from time to time. Any questions? Thank you so much.
Thank you for presenting to us.
I'll move to approve the minutes from January 13th, 2016 minute meeting.
I second.
Any, all in favor?
Aye.
Aye. Aye.
Any opposed? Minutes are passed then. Move on to the program for lead in Arizona.
Thank you. We have a speaker calling in here momentarily. This ended up on our agenda tonight because Marianne asked me if we could have a presentation on lead, which I thought was really timely, and it was very exciting to have somebody ask for some information on something, so thank you for that. So Bridget DeFore is the chief for the Office of Environmental Health at the Arizona Department of Health Services, and she's going to call in here any second, and then she's going to talk through the phone system, and I'm going to advance the slides for her, and her presentation will be Childhood Lead Poisoning Prevention, which we apparently have a problem with lead poisoning, so I'm anxious to hear this as well. We checked the system out before you.
Okay, sounds good.
Bridget?
Yes.
Hi, this is Patty, and I introduced you already, so I'm ready with the slide ticker, so go ahead. We've introduced you, and you're ready to go.
Okay, well, thank you, Patty, and thank you, everyone, for allowing me to give a quick presentation about childhood lead poisoning prevention. We're going to turn on slide number 2, and you should see the image of the Arizona scorecard for the lead screening. So very quick, just want to give a big overview of lead screening in Arizona. The screening rate is quite low. Only 24% of children living in high-risk zip code are receiving a blood lead test. In addition, physician takes a little bit too more time to report those elevated blood lead levels. They should report those results within 5 days to EDHS, and the average in 2014 was 14 days. One more thing I want to bring to your attention is that the sources of lead in Arizona, 70% of the lead is not coming from paint. We have found that the sources are coming from spices and home medicines and glazed pottery. Next slide. In Mojave County, we looked at the numbers between 2011 and 2015. ADHS received 5,150 blood lead test results, and among those, 46 children were identified with elevated blood lead level. Next slide. So those 46 kids, we split them into groups. The first bar on your left is the levels between 5 and 9 microgram by deciliter, and we have got 35 kids. And above 10, which is like the level of concern for our state rules, there were 11 kids during that time period. Next slide. So what does lead poisoning look like? Most children do not have any noticeable symptoms. The only way to detect lead poisoning is through a blood test. In children, lead poisoning can cause learning difficulties, behavior problems, lack of concentration, and if a child swallows large amounts of lead, that child may develop anemia, kidney damage, muscle weakness, and brain damage. Next slide. Why children are at greater risk? Young children are most at risk because they are still developing and they put everything in their mouth and absorb lead easily. They are more likely to be exposed to lead because they crawl on the ground, they put their hands in their mouth, so if there's any dust or lead dust on the floor, they're more likely to put that lead dust in their mouth. Next slide. There's 2 ways to test for lead. There's 2 techniques. The first one is the quick and easy. It's a finger stick. It's called a capillary testing, and that's the image on the left, the lead care 2 equipment. Or you can go for blood draw, and it's a venous, and they draw the blood and send it to the lab for lead testing. The venous testing is more accurate than the capillary testing. Next slide. So how does it work, and how do we do lead poisoning surveillance with ADHS? So all the results, all those lab results on capillary and venous testing are sent to ADHS. And every day we look at the results that are elevated. When we get the elevated results, we're going to call the physician to make sure that they're aware that that patient has elevated blood lead level. We're going to give them tips, what to look for, what could be the sources of lead, good nutrition, and make sure they're going to follow that child and do further testing. When it's elevated, when we're talking about 10, 15, 20, 25, on top of calling the physician, we will call the family. We're going to talk to mom and try to have a questionnaire, an interview, to figure out what could be the source of lead. And what we will do, too, is to offer to do a home investigation. Next slide. So the home investigation, what we do, we have a toolkit, and we're sending a team of 2 people. And those 2 people will go inside the home. They will take samples of toys, spices, They use lead check swab. They're going to rub the surface that we believe that was contaminated with lead, but it also collects samples, chips of things, toys, spices, Mexican candies, anything, and we bring them back to the state lab for testing. Next slide. So the home investigation, we go everywhere where the child eats, sleeps, and plays. Next slide. I want to talk a little bit about the high-risk zip codes and targeted screening. Next slide. Patty, are you on that slide that shows all the high-risk zip codes?
Yes.
I'm sorry, I just want to
Yes.
make sure. Are we on slide? Okay, thank you. So about 10 years ago, ADHS developed a risk-based formula to identify high-risk zip codes. And Arizona is not the only state doing targeted screening. Most of the states are trying to figure out what are the communities or the areas more at risk for lead poisoning. So in our targeted screening plan, we are using several criteria. We are looking at the number of cases between 0 and 5 years of age that got a high blood level between 2003 and 2012. We look at the percentage of the population less than 5 years of age in that zip code. We look at the percentage of the population that are Hispanic. We look at the percentage of families with income is below the poverty line. We look at the percentage of houses built before 1978. And we also look at individuals that work in agriculture, fishing, hunting, mining, construction industries. And with that formula, this is how we came up with those high-risk zip codes. Next slide. The children that do not live in the high-risk zip code still should have a test, but to figure out if the child needs a test, there's a questionnaire. And there's 8 questions. And if any of those questions, the answer is a yes, this is a trigger to test the child for lead. The question are about the same, where is mom or dad works? For example, if they're working in a stained glass business, that's high risk. If they work for recycling batteries, welding, there's a lot of jobs and hobbies that could be burning lead at home. Next slide. And turn again to the next slide. The next slide is, in general, the common sources of lead in the U.S. is mostly lead paint, like in Paki, but so lead, soil, because lead is actually occurring in the soil. And those are the most common sources in the U.S. But turn the slide. The next slide is about the common sources in Arizona. We have a different landscape, with a different situation. Our housing market is not that old. We don't have that many houses built before 1978. So what we see oftentimes is that the sources of lead are glazed pottery, home remedies, spices. Turn the slide. Imported makeup, or oftentimes makeup or crayons that people buy at the dollar store or swap meet. It could be also a lead crystal, pewter, porcelain, or toys that they get again at a swap meet, handing down antiques that may be painted with lead paint. Next slide. We also have oftentimes exposure due to the occupation of the parents, and they bring lead at home. So car repairs, construction, painting, mining, hunting, fishing, stained glass, indoor shooting ranges, those are at risk to bring lead at home. Next slide. Reducing exposure. Next slide. So when we do the investigation, the picture that you're seeing is doing an investigation. That mother was working in the stained glass business, And we were talking about how important it is to change your clothes in a separate area in the home, washing hands, making sure that the shoes are left in the garage, not in the home. But still, so what you're saying the bottom of the sole of the shoe and that pink red spot, this is where we use the lead check swab. And it turned pink because it was heavily contaminated with lead. And that child has pretty high lead level. There were lead pretty much everywhere in that home. So things that people have to do is they do vacuuming. They need to use a HEPA filter. We recommend to do wet mopping instead of vacuuming to make sure that lead is not being spread out throughout the house. Next slide. That slide, this is a toy from a swap meet. So when we do the investigation, like I said, we go everywhere where the child plays and spends a lot of time. That little shoe was very high in lead. And that child has a level at 18, went up to 30. Then we did the investigation, figured out that the shoe was the source of lead. And now that the child, within 3 months, the levels went down to 6. So we're really happy with this one. Next slide. The other one that we had, it was 2 siblings. And the reason they were so high with lead was they were purchasing the spices from India. And the content of those spices in lead was very, very high. Next slide. So very quick exposure, reducing exposure from soil and dust in the home is to make sure to take off coats and outerwear and shoes when they enter the home. They need to wash their hands after coming inside to prevent any ingesting dust. Vacuum carpets and rugs with a HEPA filter. Use a wet mop on hard surface floors and wet dust furniture and window sills. One thing it is important with preventing lead poisoning, nutrition is important to minimize the amount of lead that is absorbed and stored in the bones of the child. A child's body requires certain minerals like iron and calcium. And if the minerals are deficient into the body, lead absorption is increased. So a child has a diet deficient in calcium and iron, retain more lead than they should do. So in addition, an empty stomach absorbs more lead. So by feeding the child with healthy meals and numerous snacks throughout the day, it helps the child's body to absorb less lead. Next slide. So what we do, you should be on the slide that says encourage screening. So all children living in high-risk zip codes should receive a blood test at 12 months and 24 months of age. That's the ADHS recommendation. And if a child has elevated blood level, they should be followed by the physician and receive follow-up testing. Next slide. We do have a lot of material at ADHS. We do have postcards and flyers, and we do have a checklist for families so they can do a self-assessment of what could be the source of lead in their home. Next slide. We also have a guide for healthcare providers that gives them the questionnaire or the question you need to ask your child when they go for their well visit. We also highlight the sources of lead in Arizona, and we give them also a schedule to, if a child has elevated blood level, when is the time to retest the child, depending on the level. Next slide. So the last slide is our contact information and website. You can call us if you have any questions. If you believe there's a child that has elevated blood level, we'll be happy to schedule a home visit for that family. And thank you for having me to talk a bit about the childhood lead poisoning. Do you have any questions?
I do. You go through the testing and you find that your child has a high level. How do you treat that?
So that's a good question. The treatment, if the levels are below 45, there's no recommendation to treat the child except to remove the source of lead. Above 45, it's recommended to call frozen control, and very likely they're going to ask to do chelation and to bring the child to the hospital. But that's for those really, really high levels. Does it answer your question?
Kind of. I'm wondering, what do they do at the hospital?
At the hospital, if it's greater than 45, they call it chelation, and they inject in the child. I don't remember which chemical, which treatment they're doing, but they will make sure to replace the lead with something else. But it's a drastic procedures, and it's preferable to work with the family to figure out where is the source of lead.
Sorry, what?
When the green light's on.
I'm assuming you're meaning like a blood transfusion?
Yeah, I don't think they call it blood transfusion, but yes, it asks to transfer in the blood, remove it. Yes, and I'm not really sure how chelation works, but yes, it's a complex procedure.
Thank you.
I have a question. How are you, or have you distributed these handouts for medical providers? How are those being distributed?
So that's a good question. So we did work with AZAAP, and we asked them to distribute their newsletter, the guidance for healthcare providers. We also go to conferences. We went to every year we go in June to the conference called PEDS in the Red Rock, the meeting with all the pediatricians. We go also to the immunization conference. We go to Strong Family AZ. We go to many, many conferences too. And we go also to the medical assistant conference to get the word out about the screening schedule for children.
Would it be possible to get I don't know, maybe 50, 100 copies of that
Yes.
that we can distribute to our providers at KRMC?
Yes.
Okay.
So, Patty, is that something I can ship to you?
Yes, of course.
Okay,
Okay.
thank you.
I think our other question would be the big concern going back in the Midwest with water and the lead in the water. Have you guys found any of that in Arizona to be concerned about?
No, we never linked the lead exposure to water. And in regard to the safety of the drinking water, this is more related to DEQ. They do the drinking water testing. At times also we go to homes where they have a private well. We do collect the water well, but again, we never found a source being linked to the water.
Just one more question. So is the test just a simple blood test, I assume?
So there's two ways. There's a quick one, which is a finger stick that can be, it's a rapid response, the results right away. But
And
that
it-
one is not very.
And is that a standard test at most laboratories? I mean, are most labs equipped to handle that?
Well, most of the clinics will do it because it's in the doctor's office. It's very quick. But I would say that most of the time they're going to send a child for a blood draw, which is the preferred method because it's more accurate. That means that they need to draw blood and send it to Sonora or LabCorp or ERA. That's the other technique.
But I assume it's some kind of standard test, or that most laboratories are equipped to, it doesn't have to be sent any place special for this testing, right? It can be
No,
done at
it's
most
not.
labs?
It's not
Okay.
at all access. the access plan will cover the lead testing.
Okay, thank you.
And just so you know, all of our WIC clients get talked, lead poisoning is discussed with them, they're given information on it and referred to their provider for possible testing.
I see there are no more questions. We'd like to thank you very much for spending time with us tonight, and thank you again.
Okay, well, thank you. Thanks, everyone.
Thank you.
Good night.
Thank you.
This is Brigitte Dufour has left the conference.
Go up to CD update.
We have a communicable disease update from Anna.
Hello, I am Anna. I am back again to give your communicable disease update, and I am happy to say there has not been a whole lot alarming that's occurred in the first quarter of this year. So as normal, I've got an idea of our case counts that we've had. You're now looking at the first quarter of the past 3 years, so you can look over a time frame and see how things compare. And some things that I will point out there in those case counts is a jump in the number of hepatitis C cases, especially if you look at the number that we've investigated on top of the ones that are confirmed. And the reason for this is because we have undertaken, along with ADHS, a special study looking at hepatitis C. So we've basically taken on some extra reports of hepatitis C from laboratories, and we're investigating just some extra cases to look at a profile and see if there's anything unique that might be going on in Mojave County as compared to other areas in Arizona. So that's probably the reason for the higher than normal number of hepatitis C cases. And of course, you don't have it in front of you, but last time the influenza numbers were pretty small. This time they're quite a bit bigger. On the flip side of the sheet, we'll talk about influenza a little bit more, but we're seeing a little bit more activity. Now, if you look at the influenza case counts this year compared to last year, it is lower. The reason for that is most likely because one of our big reporters is not participating this year. So our biggest reporter that used to give us the highest number of counts is not making their reports to us this year for certain reasons, and they don't have to. It was a voluntary reporting thing. So influenza is picking up, but our case counts don't match what you see from last year. And other than that, there's a lot of what we expect at this time of the year going on. No alarming clusters or outbreaks of foodborne illness or any type of communicable disease. So plenty to do, but nothing that's been really alarming for us. The three things that I did put on the flip side of the sheet that are kind of a little bit of interest. We rang in the new year with a pretty significant case of Haemophilus influenzae, type of bacterial meningitis in an infant. And that report came to us on January 1st of this year, so it started off the quarter. And Hib, the Haemophilus influenzae type B, is the most concerning, I think it's safe to say it's the most concerning type of Haemophilus influenza that's out there. It's not influenza, it's just the name of the bacteria, but in bad circumstances, it can cause meningitis or other types of invasive infections, and sure enough, that's what it did in this infant. The infant was under-vaccinated. He or she was not yet a year old, and according to their age, if I remember correctly, he or she was of age to have received 3 doses of the 4-dose series of Hib vaccine and had only received 1 dose. So somewhat vaccinated, but not as good as they could have been. That individual was released from the hospital and survived. So it turned out to be an okay story. The significance of the Hib is that that is the one type of Haemophilus influenzae that is vaccine preventable. So that's what the significance of the type B is. There's plenty of other types of Haemophilus out there. We also assisted Maricopa County Health Department and the Arizona Department of Health Services during this quarter in investigating an outbreak of leptospirosis, which is a bacterial infection in show dogs. And the reason why we were involved in that is because the show dogs that were involved were co-owned by a resident of Mojave County. And those dogs spent time, they split their time living in Maricopa County, in Mojave County, and also in Yavapai County. And more than likely, the dogs, there were at least 9 that were involved. At least 2 died at the point that I heard of the investigation. 2 were very, very, very sick, and they thought were probably going to die. But at the point that I heard about that, the infection was probably picked up in Maricopa County. And leptospirosis is a bacteria that, as far as animals are concerned, you're concerned about their urine and picking up the bacteria for the urine. So as far as humans are concerned, in cases where there's veterinarians or animal care folks, they're usually at most highest risk of picking up leptospirosis from a dog. It's also associated with floodwaters. It can survive in water pretty well. So it's one of those concerns that you put on the radar whenever you have an issue of flooding in a community. You're concerned about leptospirosis. And sure enough, at the point under question, the place in Maricopa County where these dogs were hanging out and living, it had been raining for a couple weeks. There was a lot of pooled water, and their dogs, even though they're show dogs, they spent a lot of time outside digging and playing in the dirt, in the water, in the puddles. So that's more than likely where they picked up the illness. So our main goal there was to contact the Mojave County resident who had been also around the dogs and just make sure that they were up to date with what we knew and it matched what they understood to be the case, and basically to put that individual on a watch, him or herself, to make sure that they didn't come down with a fever or anything that could suggest an infection in themselves. So that was more or less our involvement in that cluster of illness in the dogs. And then the last piece of information there is our influenza activity. And like I just alluded to, instead of looking at the number of cases, because you never get a real good firm grasp of the number of cases of influenza in any community, what you can look at is the pattern and what's happening in terms of that activity. And so influenza activity first started increasing in Mojave County, and it matches what was seen in Arizona, but it first started increasing back in February, beginning of February, and it really kind of hit what maybe is a peak, but it's still a little bit too early to tell. Early mid-March is when, so far, we've received the highest number of case reports, and with any luck, it's coming back down the other side. But the warning there is that sometimes you can have 2 peaks in a season. So just because we might be coming down the other side doesn't mean that there's not another one coming up. And also, because of the reporting system, there could still be some backlog. And so some of those bars might increase a little bit more. And it is not unusual to have a peak of influenza in March. It might feel like it's pretty late, but that's not necessarily late. So that's what we're seeing with influenza. Any questions?
Always.
Yes.
On the Hep C, are you seeing any correlation with more intravenous drug use? I mean, are we comparing numbers as far as?
Okay, so that is, I don't know if you had a reason for asking that question, but that is part of the reason why ADHS has taken on the special project, is because of the consideration and the possibility that IV drug use, which it suggested that there are relatively high numbers of IV drug users in Mojave County. Perhaps that is pushing along some of the hepatitis C infections in Mojave County. And that is right on. That is precisely part of the reason why ADHS is taking on the special project and invited us on board specifically here in Mojave County. So that's part of what we'll be looking at. I don't know if we'll get down to the nitty-gritty details, but that's part of what might be going on in the background.
Thank you very much, Ms. Scherzer.
You're welcome.
We have a report on accreditation by Patty Mead.
This won't take long. If you'll remember, I think it was early 2014, we brought to you as our Board of Health the question of whether to proceed with accreditation, and you felt it was a worthy task for us to embark on. So with your blessing, the Board of Supervisors and the County Administrator, we, as they say, pushed the red button to begin the documentation process in September of 2014. With that, we selected one of our management team to be the accreditation coordinator. She left shortly thereafter, so the deputy director took over that job as the coordinator. And thanks to Jennifer, we were able to submit all of our documentation in September of this year. It's a huge process, over 2,700 documents. During that time, we not only lost Rachel, our environmental health manager, but we lost Christy, our nursing manager. Since September, Jennifer McNally has retired, and so has Bruce Leeming, our emergency preparedness coordinator. So in the span of the year of accreditation, I lost my entire management team except for Deb. So we are in the process of filling those positions, but this has been probably one of the most difficult challenges we've ever faced here at the health department. We are 5 or 6 positions short in environmental health right now. We are 7 nurses down out of 13 positions in public health nursing. Our department has taken a huge hit this year. So I bring that to your attention only because I want to compliment the rest of my team that are still here. Deb, Anna, and a host of other people have spent countless hours filling in for some of these jobs and have, if it hadn't been for Jennifer and some of these people filling in and completing this, I don't think I would be here today telling you we are actually able to do that. So since September 16th, what happens then is the site coordinator, you're assigned a site coordinator, a FAB coordinator, Public Health Accreditation Board coordinator. She reviewed our documentation. She sent back a few things where she was worried about dates and detail stuff. And then we sent all that back, and then we were assigned our site visit team. They want to make sure you don't have a conflict of interest, that you don't recognize them or that you don't know them personally. So our site visit team has been assigned. And then they had 10 to 12 weeks to review all of our documents. And at that point, they send out their review and ask you for any additional documentation they might need to explain what you've already submitted. At that point, we had only 9 revisit questions that they asked and additional documentation, which, from what I understand, is pretty good. We did really good on that, thanks to the team and Jennifer. Since we resubmitted that, we just received today our schedule and our schedule of events for the 2 days. Our site visit will be May 10 and 11. Between now and then, we have been actively having mock site visits, domain visits with all of our team. as you may remember, accreditation is divided into 12 domains, each a different topic that public health addresses. And so we are practicing how to address each of those domains and what we submitted. And what we're having to do basically is train staff that weren't involved in submitting of the documents to be the ones that talk about what we do with regards to that domain. So it's a real challenge for us. There are 97 measures that they look at, and we were only 9 of them were we asked to address additionally. So we're pretty pleased with that. We think that's good. During the site visit, so between now and then, we are having a mock site visit on April 26, 27. We are doing our domain practice sessions. We are making sure our area looks clean and neat and tidy, and making sure everybody's ready. We're excited because we feel like this will be our opportunity to showcase all the good things that we do here in the health department. When the site visit team gets here on the morning of May 10, they will come and they will, first of all, we'll have a short meeting and they'll give their opening remarks, and we'll welcome them. And then they'll take a tour through the area just here in Kingman. Even though we also have offices in Bullhead City and Havasu, they are not able to go to the clinic sites. So it will just be here in Kingman. Then they'll have an hour discussion on the community health assessment and the community health implementation plan. And then they'll have a discussion on our strategic plan. And then they'll begin concurrent domain interviews. So because there's 3 site visitors, they'll look at 3 domains at once. One site visitor will be addressing one domain, one the second, and the third. So trying to coordinate all of that and make sure the same staff are not in the same domains. We were working on that today. Then on the afternoon of May 10, the first day, they will want all of our partners together. So we have asked all of the people that we work with on a daily part of our business, we've asked them to come and be part of that, and they will talk to them about how we do business with them and how we partner. Then they will have a governance interview. They'll do more domain interviews, but the next morning they will do a governance interview. So they will meet with some members of our Board of Health, with members of our Board of Supervisors, and with the county administrator. And that's about, I believe, an hour while they will talk and find out what the relationship is like and what you guys know about us. So I'm looking for members of the Board of Health to volunteer. I've already asked some of you, but I'm hoping that some of you will volunteer to be there for that governance interview. Then they meet with me, and then they have an exit session and closing remarks. And they apparently, during that exit session, tell you what they consider to be your 3 weaknesses and your 3 strengths. And then the site visit's over, and they make a big production of you pushing the red button that says the site interview is over. And at that point, I think we'll all take a big breath, and then we're going to have an ice cream social to celebrate. And then what happens after that is they take 2 weeks to write their report from their visit. They look at everything. They look at the documentation that we submitted, and they look at the interviews they had with us and make sure that what we submitted as documentation actually matches what we talk about and what we look like we do. And then they submit that to the Public Health Accreditation Board of Directors, and supposedly they meet every 3 months, but I think right now they might be meeting monthly because they've got so many health departments in the queue to be accredited. So we hope to hear by July, the end of July, whether we're accredited or not. If we are accredited, there will be a huge celebration of which you'll be invited. The other alternative is sometimes they give you an action plan of a few things they want you to additionally address, and then you provide that information to it, and then hopefully you hear after that you're accredited. So we're hoping we don't have any additional action plan items, that we are fully accredited by July. And then we can go back to just doing our one job, because it feels like right now we have 2 jobs. It's a lot of work. I cannot begin to tell you how much energy and extra work this is with a short staff. It's just been a real struggle. So I'm not complaining. I'm just telling you I'm so proud of the team and the effort that's gone into this. It's something we should really be proud of. Any questions? So May 11 from about 10 to 11, I believe is the time they've set. We need Board of Health members to be there and talk about, hopefully you'll talk about the good relationship you have with us. We would like to have a practice session with Board of Health members so we can go over specifically the kinds of questions they ask and make sure you're prepared as you can be for that. So we'll be getting together with you by Friday to come up with a time for that.
Patty?
Yeah, Terry.
So once you receive the accreditation, then what's the renewal process and how often does that happen? And
Once you receive the accreditation, it's my understanding that the clock starts ticking that day and you have 5 years to prepare for the next accreditation process. So hopefully we still receive funding from the Arizona Department of Health Service, because if you'll remember, this was almost $30,000 to just pay the fee to be accredited. So it's a costly endeavor. And I'm hoping that we'll see value from it. I'm convinced that we've already seen a ton of value within the department. It has forced us to look at business principles that we had been lazy about, and it's helped provide a really good business structure for our department. We do quality improvement now as a regular part of our business. We do performance measurement. We have a strategic plan that almost every employee knows exactly how what they do fits into that. And we are working within our community health assessment to do great things in the community. It's brought a lot of partners together. I have a close relationship with Terry because of the hospital. And so there is really nothing bad about the process except for the fact that during this time we lost so many key people. It was difficult to keep all this documentation and going, but we did it. Thank you.
Well, Patty, I just wanted to say that you were giving you were commending the people that work in your department, and I think you are absolutely amazing.
Thank
Your
you.
commitment and your time and your energy to keep all of this going and bringing it forth, and I personally just want to say thank you.
Thank you. Thank you. I appreciate all of your time. This is a voluntary job, and we really need your support because you are our liaison with the community and you're the liaison with our Board of Supervisors. They're so busy that it's your job to help communicate what we do to them so they can provide the support we need financially and administratively. So thanks to all of you.
Patty, before, and forgive me, I was late, but was there any,
Maria was here and gave an update on the mental health workforce.
have you informed the rest of the board about where we're at with initiating another health assessment?
No, we've been so busy. Technically, nonprofit hospitals are required to do a community health assessment every 3 years, and with accreditation, public health departments are required to do it every 5 years. Now, the governing agencies that came up with these timelines, I wish they'd have talked so it would have been the same for both of us, because we partner. They encourage you to partner with your nonprofit, and we would have already been talking about this with KRMC even before the requirement came about. And we really want to get the for-profit hospitals involved in this, but they're not required to do it, so it's a little bit different. So we've been so busy with developing our community health implementation plan and making sure our workforce groups were working on their issues. It's a lot of work. Terry called me a couple weeks ago and said, I have some really bad news. I'm stressing out. I just realized that we need to do another community health assessment by the end of June to meet the IRS requirement. Well, fortunately, we had already been talking about it. We just didn't know it was quite that soon. So we need a consultant to help us with this. It's such a big project, and with limited staff, between KRMC and the health department, we share the cost of it. So I had already looked at consulting firms that specialize in helping health departments do the CHA, and we are working with Pinnacle
Pinnacle Prevention.
Thank you. they graciously agreed to contract with us and get it done for us by June 30. There's still maybe, the health department is under that timeline, so there's, the IRS part will be done by June 30th, but there may be some things going on after that. And then what we will need help with, again, is if anything is different in this community health assessment from the one we did 3 years ago, we'll have to figure out how to incorporate that into our current improvement plan so it all meshes together. We've got to figure out this timeline. And part of what we're doing is we don't expect to be perfect at this. We've just started doing all of this in the last 3 years. We're just trying to get up a system here so we keep the momentum going and don't let these little inconveniences mess up the way we're doing it. But we feel really good about our group, our workforce groups right now. We got a lot of partners working with us, and I think eventually, you know, we are really going to see some things that improve health for our citizens. I really think it's going to make a difference. And eventually, Terry's and my dream is that there will be so many people involved in this that all the agencies that have anything to do with health disparities or health will be partners in this community-wide assessment, planning, and implementation, and that if you apply for funding within this county, with any of our foundations or with any agencies, state or federal level, one of the key factors will be, are you part of this partnership, and are you making sure that this money is not going to be duplicated, it's not going to be competitive with somebody else in the county, and that you're not going to waste resources. That's one of the problems we've had forever, and not just our community, but everywhere, is people applying. One pot of money comes out and 50 agencies in the same area applying for the money competitively, instead of working together and figuring out, okay, here's this pot of money, who should get this, where is it best used, so that we all work together to improve. You'll see a lot more improvement in health when you work together like that. So that's our ultimate goal.
And I'd just like to add that the assessment process will involve, so during the month of May, there will be focus groups and key informant interviews that the consultant will be conducting, and a community survey on health. And so there's both qualitative and quantitative data that will be collected during this process. Of course, they'll be looking at, you know, disease statistics, and Anna knows we got involved in that quite a bit the last go around, but the end result of the assessment will be a report that takes a snapshot of a lot of health indicators within the county, and then also the qualitative data input from members of the community. So it is a pretty good look at where we stand with a lot of different health indicators.
And as Board of Health members, you will probably be part of the key informant interviews. So if somebody from Pinnacle calls you for a half an hour of your time, I would hope that you would participate in that. The other thing that's important to remember is that it left me. I'll think about it. Something you said, Terry, about what's going to happen between now and June. One of the things that happens many times with these assessments, and it happened the first time and it'll probably happen now, is the things that lead the health problems in your county, for example, in ours it's cancer and heart disease, are not what sometimes the community members see as their problems. So that's what happened in the last one. The leading indicators that cause death and morbidity here in this county are not what the community thought were their problems. They picked economic conditions, mental health, substance abuse, access to health care. What was the fifth one? anyway, they weren't the lead, they don't
Oh, youth.
sometimes, youth risk protective factors, which is youth feeling like they belong and feeling like they're part of their community, a sense of belonging. So those are the things the groups have been working on, but they don't necessarily have to do with what we're dying from here. And those are still things that the health department needs to oversee and address and try to address. So we still have our tobacco program and all those other programs that try to work on those things as well. It all fits together into that strategic plan, if you'll remember, that we talked about. Thank you.
There's a call to the public? Next on the agenda? Is there a motion to adjourn?
I move to adjourn.
All in favor?
Aye.
We're adjourned.